Hello, everyone. I want to welcome everyone to our bioethics alumni speaker series, where we invite back folks who have graduated our amazing program and spent time with us and have gone on to do truly amazing work in their field. So we can all learn from them and celebrate the cool things that they are doing. You all know me. I'm Stephanie Kokora, one of the faculty in the Center for Bioethics. And I'll be joined here today by Dr. Terri Major-Kincade, a brilliant colleague and friend. And just to sort of highlight, we asked her to send a short bio, and she sent like multiple paragraphs because she's doing so many cool and interesting things right now. So I'll tell you a little bit about her. So Dr. Terri Major-Kincade is a double board certified neonatologist and pediatrician with over 25 years of experience as a clinician in neonatology, pediatrics, health equity, perinatal health disparities, and neonatal perinatal palliative care. She is an associate professor of pediatrics at UT Health Houston McGovern Medical School and Children's Memorial Hermann Hospital, and is the medical director for pediatric palliative care. She holds an MD MPH from UCLA School of Medicine, pediatric residency and neonatology training from UT Southwestern and UT Houston, and pediatric hospice and palliative medicine training at Baylor College of Medicine and Texas Children's Hospital. Her national partnerships include PLIDA, Pregnancy, Loss, and Infant Death Alliance, and the Pampers Womb to World Advisory Board. Her research interests include identifying barriers to perinatal and pediatric palliative care for marginalized populations, provider-patient communication, narrative medicine, bioethics, and navigating moral distress associated with the care of infants and children with life-limiting illness. She most recently co-authored a chapter in the newest edition of the Handbook of Perinatal and Neonatal Palliative Care Guide for Nurses, Physicians, and Other Health Professionals, and the 10th anniversary edition of Merenstein and Gardner's Handbook of Neonatology. She is a 2019 to 2020 class graduate of the Children's Mercy Certificate Program and remains an active alum who participates as subject faculty in many areas related to her expertise. And today, Dr. Major-Kincade will be telling us about balancing equity, empathy, and institutional interests in pediatric iatrogenic harm. So welcome, Terri, old friend.
Thank you so much. Hey, everybody, I'm super excited to be here. Before we get started, I just want to give a shout out to the Children's Mercy Pediatric Bioethics Alumni faculty and thank them for this invitation. I am super excited to be talking to you guys today about this topic. It's a topic that's really near and dear to my heart. I'm especially looking forward to the discussion and the questions that may come up following this presentation. So over the next 60 minutes or so, we're going to talk about some frameworks around bioethics in the setting of pediatric iatrogenic harm. And we're going to specifically talk about disclosure and the moral courage it takes to work well inside of imperfect systems. They asked me for a theme song right before I started, and I was thinking about this topic. And I think the best theme song that I can give regarding this topic is Waiting for the World to Change, and just reminding everybody out there that in order for systems to change, we have to change, and hopefully us all leading the way can continue to work together to make sure that children get the best care as well as their families in the safest systems. So before we get into this topic, I wanted to just kind of start with why this is so important to me. And the reason it matters to me is that even though I'm 26 years into my career as a neonatologist and 4.5 years into my career as a full-time palliative care physician, I wanted to just name that it's true that some losses echo louder than others. Some losses carry a bigger weight, and we know that in pediatrics, the death or serious harm of a child sits inside families for generations, and it sits inside of us differently than adult losses too. And one of the things that sits inside of me is a micropreemie death that occurred in a smaller community hospital many, many years ago. It visited me in quiet moments, whether the child might have done better in a larger, more well-resourced level 3 or 4 center, a place with more experienced staff or more specialized care. And this uncertainty is something that keeps me up at night and makes me question, can we do better? Can we prevent this for the next family? And I think that's something that we all should think about as we navigate these spaces. So we have 3 objectives today. The first is that we're going to differentiate concepts and contributing factors that contribute to pediatric iatrogenic harm versus adverse events. We want to make sure that we're not intertwining those definitions, because sometimes we use those definitions interchangeably in the hallways when speaking to our colleagues, but they really mean very different things and they require very different responses. The next thing we're going to talk about is the moral distress in clinicians. And when I say clinicians, I mean the entire care team that is impacted anytime we have iatrogenic harm or an adverse consequence. And we're going to end with a couple of frameworks to help us kind of navigate the initial process around pediatric iatrogenic harm, as well as the disclosure for pediatric iatrogenic harm, as well as taking care of ourselves. So the first thing we're going to talk about is just definitions. So these definitions are from AHRQ. I'm sure they're familiar to many of us, but I just like to start with the framework that we are representing two overlapping concepts. Understanding the distinction is the first ethical step. So first, adverse event. What is an adverse event? An adverse event is any unintended injury caused by medical care rather than the underlying disease. And notice what's not in the definition, which sometimes comes along sometimes subconsciously when we're talking about events in the hospital. This definition does not include fault. It does not include blame. It does not include intent. So for example, a postoperative infection, despite a perfect sterile technique, is an adverse event. A drug reaction and a properly dosed medication is an adverse event. Harm happened, care did cause it, but no one made a mistake. So harm can occur without any error ever being made. Whereas a medical error is truly a failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. So we know errors are about the process. And importantly, most errors do not reach the patient, thank goodness. They're caught by nurses, pharmacists, or safety checks that our systems are designed to protect. But an error that reaches a patient may or may not cause harm. And the reason we want to have a distinction is because we know that the ethical obligations, depending on these definitions, are different. So every adverse event demands disclosure and support. However, every error, whether it reaches the patient or not, demands a system learning. So confusing the two can really be problematic later, and we're going to see that in some of the case vignettes and also how our staff are able to navigate this process. So what is iatrogenic harm in pediatrics? In preparing for this talk, I learned that the root for iatrogenic, iatros, comes from the Greek word physician, from the Greek root physician cause. So when you say iatrogenic harm, you literally are saying harm caused by a physician. Physician caused harm. Harm that results from medical intervention, regardless of whether an error occurred. Physician caused harm. Not physician blamed, not physician shamed, but it's named. Because if we can't say the word, then it prevents all the subsequent steps that allow us to improve our systems. So iatrogenic harm refers again to harm resulting from medical care itself. It can be procedures, it can be medications, and we know in pediatrics, because of weight-based dosing, we have the opportunity to make tenfold errors there, devices or systemic failures rather than the underlying disease. And that alone separates pediatric patients from adult patients. We have the developmental vulnerability. Their bodies are more vulnerable than the bodies of adults. We have the issue of dependency and surrogacy consent, where families are making decisions for their children, and the children are completely reliant on their surrogate decision makers to make these decisions, which may lead to iatrogenic harm. And we also know that there's a long life horizon, that consequences for today, something that may have occurred that affects hearing, for example, can affect children for years, months, decades to come. So what are the 6 things we want to think about in terms of these pediatric patients versus adult patients, and why the ethical landscape is different? We mentioned dependency and assent. Children can't consent. They can't provide assent that's age appropriate. They are relying on adults. Part 2, we talked about surrogacy and shared decision-making, and those of us who do this work every day mentioned the concept of best interests. We allow for the fact that parents are acting in the best interests of their children as surrogates. We know that there's a heightened fiduciary duty because we have a responsibility as pediatricians, those of us caring for children, to protect vulnerable patients. And it extends beyond the hospital. We think about the community, we think about the home they're going to, we think about the school system. We think about equity that is related to geography, and we know that access to specialized pediatric care varies by location, and we know that populations that are in more rural areas will have disparities that can lead to harm that is related to the system, not something we did directly. I mentioned the developmental vulnerability as well as the long life horizon. So we want to hold all of these ethics concepts in mind as we navigate the next set of slides. We talk about some case vignettes and the process around disclosure. So consent, disclosure, equity, safety, all of this carries a heavier weight when we're speaking for patients who cannot speak for themselves. And it also may speak to why we as caregivers may carry a different kind of burden when navigating this process. So a question that won't let go. I mentioned a case I had many, many years ago, have changed the specific components of that case and just summarize some other cases that have come up for me in my clinical world, which is as a neonatologist. As I'm navigating this case, I challenge you to think about cases for you in which there were untoward outcomes that have allowed you to reflect if things could have changed, if something had gone differently. So imagine an extremely preterm infant, 24 weeks, 500 grams, delivered at a smaller community hospital. Mother comes in preterm labor, 24 weeks, emergency C-section, not uncommon in the world of neonatology. At this particular unit, they had just become a level 3. They were approved to be a level 3. They're designated a level 3. But this was the smallest infant ever cared for in this unit. The infant required resuscitation, mechanical ventilation, with limited NICU resources on site, and staff learning advanced ventilator management in real time, because this was the first a really small baby that had been in this unit. Baby was initially very stable, later developed some complications related to extreme prematurity, and we were unable to really ascertain the individual impact of confounding factors such as evolving staff education around the routine care of micropreemies, limited resource, delayed recognition of changes in the baby. So if I think about the system issues for this baby, there were some facility limitations. It was a level 3 with limited subspecialty support and a low volume unit growing as a level 3. There was some challenges with recognition that neonatal risk may not have been recognized in real time. And then the question about transport, if transferred to a higher level 4 or a level 3 with a higher volume, was not considered initially as infant was stable and met criteria to stay there. But one of the questions that remains is, would transfer have changed this child's story? We cannot know, but the asking matters. We know that in this particular population, wherever you are, there's always can always be an untoward event that can lead to a shorter life. But there are some system issues that we thought about when we went through our RCA. So that's the question that stays with me. Community hospital level 3 versus tertiary level 3, limited resources, smaller team, not as much experience, building protocols, growing to where they want to be versus a more advanced hospital with a larger team with more extensive experience. We all navigate systems that have to think about delay of escalation of care. We all navigate systems that may have resource limitations. We all navigate systems that weigh the pros and cons versus separating a family versus not separating a family. And the question still remains. So how do you do a drill down on your system when these types of questions present themselves? So in this particular scenario, I'm using the model of NICU levels of care, but in whatever example is coming to your mind, I would like you to think about what risk mitigation strategy data exists that allows you to determine the pros and cons when there may be system failures. So we know for the NICU, the AAP has put forth standards of care. We know that level 1 is a routine nursery. We know level 2, for those of you who don't routinely work in this environment, is typically greater than 32 weeks, greater than 1,500 grams, stable infants with limited ventilator support, do not have the ability to take care of kids that have sustained critical illness. We know that level 3 can cover all gestational ages, sustained life support, all matters of ventilation and all advanced interventions with 24/7 staff. And we know level 4 is the highest tier, often having the more access to all the surgical specialties. And the ethical goal for all of these scenarios is right baby, right place, right time. So what do we know about the right baby, right place, right time? We know from the landmark study from Dr. Karen Phibbs that was put forth in 2007, where he did a retrospective analysis of very low birth weight infants, evaluating the morbidity and mortality outcomes across a variety of level of cares, which clearly showed that among very low birth weight infants, mortality was lowest in hospitals with NICUs that had the highest level of care and the highest patient volume. So we know that the odds ratios range from very low, from the lower end 1.19 to as high to 2.72. And that was specifically related to volume and level of care. And so those are things I think about whenever I'm working in different systems. At this point in my career, I have been in practice 26 years. I've worked in 6 different states and over 30 hospitals. And this is something that I think about whenever I see system challenges. And it continues to stay with me about challenges that I actually have no control over, that the staff has no control over, the family has no control over. So we know that the ethical obligation to consider that equity is being applied when care is being provided extends beyond the bedside, because some of these situations present themselves well before patients show up in our respective hospitals on our respective units. So we know that risk-appropriate care is equity, and I will end on this slide using the NICU as an example. We know that we have sound evidence that babies will do better in higher level of care if they're sicker babies or higher volume units. But my question to you is beyond that. What blocks appropriate care? What are the barriers that we have geographically? What are the barriers we have for transporting patients? What are barriers we have for delayed recognition or triage of mothers and babies? We know we have great evidence to show that it's better to transfer mom than the baby. And what bias may exist in referral patterns? So those are some of the things I think about that I want us to remember that framework as we move forward to disclosure. So moving away from that case, I want you to hold in your mind whatever scenario comes to mind when you think about system failures that may have contributed to pediatric iatrogenic harm. And I want to remind everyone that in pediatrics, typically, and really in most iatrogenic cases that lead to untoward consequences, there's not a solo event that happens. There are typically system failures at multiple levels that lead to untoward outcomes. And it's how safety science has been built around improving outcomes for patients. So let's move forward from pediatric iatrogenic harm has occurred. It has occurred, and now we want to think about how do we provide this disclosure to patients, and how does our hospital support us in providing this disclosure to patients? So what we owe families and how to say it is what I want to talk about in this section. If you look at the top of this slide, it begins with a quote that the AAP includes in their policy statement about disclosure of adverse events from a family. We didn't need perfection, we needed honesty. And I want to name that what we owe families after iatrogenic harm mostly is truthful disclosure and genuine apology. We don't often work in systems that allow us to say that. And sometimes we know what has occurred, but we don't know how to share it with the families. And so we're navigating that with our risk management teams or our disclosure teams. But what we owe families, the very first step is an immediate presence. An immediate presence once we're aware that harm has been done. So we don't want to make families wait alone. We want to provide a clear statement that an event has occurred, and we want an initial assessment, a commitment to investigate, and a timeline to follow up. That can be very general, and navigating uncertainty when we don't have all the information can be really, really challenging, which is why it's important to talk about what the framework is going to be and what our process is going to be when we talk to families. The second thing is we can tell them what we know and what we don't know. The uncertain burden is immediately halved. You can say, I know that this has occurred. What we don't know is how this occurred or why this occurred, and we are currently investigating that process. Number three, I want to make sure that we lead with empathy. We know from data for families who have navigated a process where disclosure happened that leading with apology is how they can navigate grief. Apology can be really complicated in medicine because we associate apology with liability. And I would challenge those of you who are listening today to see what your state's laws are around apology laws. Many states have laws noting that apology in the moment is a sign of empathy and not connected to liability. So we do want to express genuine regret that this has happened to their child, not just for the clinical event, but that their family has experienced this. We want to avoid defensive language or blame shifting, and we want to apologize depending on what the guidelines are for your hospital or for your state law. But you definitely want to lead with empathy. And you want to have an ongoing relationship with the family through the process. So you want to make sure they have their contact person. You want to have ongoing dialogue as a partnership. And you want to make sure that they know who the contact person is going to be. And you want to let them know when you're going to follow up, when you're going to check in with them again. And the reason ongoing relationship is so important for families is one of the most motivating things for families who are navigating a legacy after harm. And it may not be a medical error that caused fatal consequences. It could just be communication. Sometimes my team is called often to mitigate communication after a complaint to a patient liaison. Families want to ensure that this does not happen to another family. Very recently, I had a family say to me, I know that if it's happened to me, it has happened to someone else. You guys have a system problem. And so I really appreciated the way she framed that. And just remembering that agreeing to partner and collaborate with families, it is a way to allow them healing and a way for them to have a legacy to prevent this for the next family. So what types of frameworks can we use? The first thing I want to do is compare the ethical principles that we're holding in place with the steps for disclosure. And then I'll share with you a vignette for what this may seem like in real life. So the first thing is veracity. Truth-telling, we know, is very core, is core to bioethics. Nothing begins without truth-telling, and it really is the moral foundation of disclosure. And for those of you who may be in environments where you feel like you don't have psychological safety for truth-telling, this can be compounded and lead to moral distress, which we will talk about later. Non-maleficence. We want active care for the harmed child and the family. Harm has occurred, and we want to make sure that we mitigate any future harm. Beneficence. How does it show up in the face of iatrogenic harm? It shows up by a true investigation and a prevention of the recurrence of this problem. And then justice. We talked a little bit about justice using the example of triage for neonatal levels of care, but you can think about it within any environment that you work in, making sure we have equitable access to risk-appropriate care. And then fidelity. We owe a loyalty to patients, not just our institution. We owe a loyalty to patients as well. So what do those steps look like to resolve it? If you look to the right of the ethical principles there, you see the first thing is identifying. That's part of your truth-telling. We're going to document this event. Activation. What is the activation system at your hospital? What disclosure protocols do you have? What personnel need to be notified in terms of your risk management? What is going to be the response and the disclosure? Who's going to lead that conversation? And what about the response time? The investigation. What does that look like in terms of your root cause analysis and the true fact finding so that we can have collaborative learning? And then the resolution. What is your prevention plan and follow up to make sure this doesn't happen again for families? And so in terms of who should be involved, at the bottom, you see disclosure lead. That person should be identified. It should be somebody that's a trained communicator in family meetings. It may not always be the clinician involved with the team who's facilitating, although they should be there in the process. The care team, the clinicians involved in the event, the support staff, everybody involved and tangential to this event should be included in the conversation. We do know that many second victims carry the impact of iatrogenic harm long-term because they weren't involved in the initial discussions and it wasn't attended to how they felt about the process. Obviously, leadership is going to be there. Ideally, you want the conversation with families to happen within 60 minutes of the event, which sounds scary. Sometimes people are still trying to gather all the facts in, but at the very least, you can give a warning shot that something has happened. Ideally, you would like to be able to get follow-up within 24 hours and updates, depending on what is navigated with your risk management team. And you want to have regular checkups throughout, and then documenting your RCA obviously separately from the medical chart. So how do we communicate uncertainty and apology? I talked about this is the hardest part of disclosure, and honestly, it's the part that's not taught well in most of our clinical training. How do we communicate uncertainty and apology? How do we name that in a way that we align with the family and that we don't imply liability? So here are some examples you can think about when the words feel impossible. So you can say, for the acknowledgement, once you guys have your meeting and what the disclosure plan is going to be, something has happened during your child's care that I need to talk to you about. I want you to know that we take this very seriously. You can see you can speak in person. Ideally, you don't want to be giving this information over the phone. You want to have a private setting. You want to sit at the family's level, eye level, not looking down on them or in a very hierarchical fashion, and give them time to react, speak, and then quiet. And then you're going to have the empathy statement. I'm so sorry that this happened. I can only imagine how frightening this is. Your child's safety is our first concern. Avoiding blaming language, premature promises, placing blame on others, or rehearsed corporate phrasing. And sometimes the biggest mistake we make is sounding too certain at the onset or hiding behind legalese. I can't say anything until risk management further discusses that. I can't talk to you anymore. So finding a way to align with families, let them know that we're sorry that harm has happened and let them know that we are looking forward to identifying what has happened in this process. And then an honest explanation. Here's what we know so far. Here's what we don't know. We are actively investigating and we'll tell you what we learn when we learn it. So distinguishing the known from the unknown very clearly, explaining what under review means, share who is investigating, and commit to your timeline. And then we will meet again tomorrow at 9 a.m. or whenever it's going to be to share what we've learned, name a single point of contact, whoever that may be, offer chaplain or social work support, and document all these conversations. So what have we learned from patients that have really transformed the way we navigate patient safety in the pediatric world? The first person I want to mention is Josie King, which I'm sure many of you in this audience may be familiar with. But for those of you who may not be familiar with the case of Josie King and Josie's mother, Sorrel, I would encourage you to become familiar. So Josie King, this case happened in 2001 at Johns Hopkins. She was 18 months old. She was admitted after a skull burn injury, and she recovered from that burn. She was moved out of the pediatric ICU. She initially healed well, her skin grafts were successful, and she was acting like her old self within weeks. She deteriorated, became pale and unresponsive, and she died February 22nd, days before a scheduled discharge. In the interim, in terms of the symptoms that were noted, she died from dehydration and a narcotic that was administered against her family's stated concerns. Her mother, Sorrel King, watched her daughter deteriorate and repeatedly told nurses and physicians that Josie was thirsty, that something was wrong. Those concerns were not adequately escalated, and the narcotic was given despite the family's protests. And at that time, she was considered to be one of the healthiest children on the unit, and she did not leave the hospital. So I bring this case not to indict Johns Hopkins, because this case really changed the landscape for the way we navigate safety for patients, and became a landslide moment for Johns Hopkins in leading the way for navigating patient safety and inspiring the patient safety movement. And we learned several things from that case. We learned about transparency. The primary clinician involved in the case openly acknowledged error. There was a cultural shift that moved from errors just happen, they're inevitable, to we need to be accountable and have some safety science to mitigate the possibility of errors. And it led to the founding of the Armstrong Institute for Patient Safety and Quality. So 4 lessons we've learned from Josie and her mother, Sorrel, and there's some amazing videos on that website related to patient safety and advocacy from her. We learned about the importance of apology and open communication from the top down, from leadership. The very first thing that was said to the Kings was that the hospital team was sorry and that they would find out exactly what happened. Another thing that happened in that system was people did not feel empowered to speak above people who may have been in charge of the case, or there was a hierarchical system like many hospitals have. How can you speak over the person who is directing the care if you feel like the care may cause harm? So a central lesson was that we need to empower all team members, especially our nurses, to be able to intervene if they witness dangerous practices. And people need to know if somebody above them is doing something dangerous, that they have every right to speak up. And I think we've come a long way in hospitals, but I navigate care every day and hear from our staff, our interdisciplinary staff, our nursing staff, that sometimes people still don't feel safe to speak up. We want to treat safety as a science. And Johns Hopkins began treating safety as a science and using data to develop clear checklists to measure, learn, and improve. And really using all of this not as a blame system, but as a way to make sure this doesn't happen for anyone else. And then we got the development of RISE programs. And so many of you may have RISE programs at your hospital, resilience and stressful events, where we begin to really attend to moral distress that is experienced by caregivers caring for patients who have experienced adverse events, iatrogenic harm, and making sure that we attend to the coping and the well-being and the integration of this process so that our healthcare teams can be stronger as they navigate the next process and have safe spaces to talk about how that felt. A similar landslide moment in the case for patient safety and pediatric ethics is the Lewis Blackman story. And I'm not sure how many of you are familiar with Lewis Blackman or his mother, Helen Haskell, who channeled her grief into advocacy all the way to Congress in South Carolina. And so in this case, Lewis Blackman was 15. He was a healthy, athletic ninth grader who underwent elective surgery for a pectus excavatum at a major academic medical center in 2000. Over the next 4 days, he bled to death from a perforated ulcer that was never recognized. His mother, Helen, watched her son deteriorate through the entire weekend. Vital signs were abnormal. Pain was not controlled. He had cold skin. She asked repeatedly for a more experienced physician. She was told an attending would come. No attending came until it was too late. There was weekend coverage, limited. There was trainee heavy staffing and no clear escalation pathway for the family. So a young, otherwise healthy patient assumed to be very low risk for surgery. Every one of those factors that I just named led to his untimely death. And Helen Haskell has since led one of the most important patient-led advocacy moments with the Lewis Blackman Hospital Patient Act. And Lewis died because hierarchy mattered much more than his mother's alarm. She was told, don't worry, he's fine. And she never actually got to speak to an attendant until he was actively dying. So what does the Lewis Blackman Hospital Patient Act entail? It entails badge requirements. So when you come into a room, every patient should know who you are, your role on the team, and your role in relationship to their loved one. There should be written information, and patients should know who's caring for them. And so I think about the Lewis Blackman case whenever I go into a room and I see a board that's written with the names of the team and the plan for the day. Families can see that. I can see that. She established the H system, a helpline for parents that allows for escalation and for staff, for nurses, where you can escalate at any time somebody requests to speak to an attending. And it allows for direct access to attending for family members at any time. And I think about the way we navigate care today, and I feel like it's relatively easy for patients to identify attendings and get to the attendings. But at this time, it wasn't very easy for Helen Haskell and Lewis suffered as a result of it. And maybe you work in a system where they're still not as easy as you might think it should be or could be in order to empower not just our patients, but our staff. So this case allows for dignity and transparency and reminding us that families are not just at the bedside. They are partners in the care. They're not passive recipients. And the person who knows the best about what's going on with the patient might not be the person with the badge and the white coat, might be the person that came with them from home. So what does that disclosure conversation look like when the adverse event has happened and you have to respond to a very direct question? What happened to our child? We were told everything was going well, and now we're being told there's a complication. Remember, we're going to say what we know and not and name what we don't know. Something went wrong during the procedure. I'm so sorry. Right now, we know there was an unexpected bleeding event during the catheter placement. We don't yet know the cause. We're meeting again tomorrow at 9 a.m. to share what we've learned. Was that a mistake? Did somebody do something wrong? We don't know yet all the causes, but what I can tell you is that we're reviewing everything carefully, the procedure, the monitoring, the response time. We owe you the truth. We will tell you what we find, and we'll do this to prevent that for others. So prompt acknowledgement, honest explanation, empathy and apology, commitment to follow-up, and a clear timeline. Those really should be the steps that we are navigating for any disclosure conversation, obviously in context with our risk management teams and leadership. So it's easier said than done, right? I've said to you guys a few things about frameworks. I've given you some scripts. That's all great, but we all know that when it actually happens, it can be harder to speak that than what I'm saying here. And having been in those situations, having to stand up or question, can we do differently? Could we have done something differently? What do we owe the family? What do we owe the patient? And what do we owe the system? These things can be hard. So how do we navigate courage in those spaces? The first thing I want to name is we all work at institutions. Hopefully we all love our jobs and we're happy at our institutions. And hopefully we all work in systems where we feel safe, but we know that's not always the case. And so what would we like to see in a healthy institution? We like to see an accurate fact-finding process that includes a due process, thorough investigation, and a fair evaluation. We like to see privacy and protect confidentiality while ensuring appropriate disclosure. We would like to learn from these errors so that we can improve and not be blamed. And the fear of being blamed, and sometimes the fear of being sued is what keeps people from being able to share. We would like to have caregiver support. So even if we have a nice fact-finding process, if we don't have something for caregiver support, that can lead to second victim challenges, moral distress, moral residue, and for some people, burnout and leaving the field. So those programs should be intact. And then transparent disclosure processes. What are the clear process to communicate with the family? I want to make sure I'm following my institution rules, but I also want to make sure that there is a disclosure process. If trust is harmed, what does that look like? We know that trust, when trust is eroded, it can look like concealment, retaliation, intimidation for speaking up. It can look like being very ambiguous about the facts. It can look like being blamed without learning from the process. It can look like choosing reputation protection over safety, or it can look like delay or avoiding disclosure altogether. So what frameworks do we have for disclosure? So one framework for disclosure that's been well established is from the Agency for Healthcare Research and Quality called the CANDOR approach. CANDOR stands for communication and optimal resolution. Wouldn't that be great if everything is always resolved optimally? CANDOR, C-A-N-D-O-R, and some hospitals actually call their disclosure teams CANDOR teams. So we want to identify the CANDOR event, recognize it, name it, identify it. We want to activate whatever our disclosure system is. We want to respond, that initial conversation we talked about, empathy, acknowledging harm, what we know and we don't know. We're going to have the root cause analysis, and then we'll have the resolution. Transparency really is the most important thing. And even when families hear about really egregious errors that can happen, families have an amazing ability to hold space for that. When they don't hold space for that can be when we are in situations where disclosure did not happen. So how do we escalate? So this talk is not about calling in anonymously to the medical board because you feel like you observed something that was different than the way you might have approached the situation. And we call that the escalation ladder. And at the end of this talk, you guys will receive a couple of handouts. You'll have a link that talks about the CANDOR approach, the escalation ladder, and a disclosure script. And I just want to talk about this escalation ladder includes specific rungs. And most of the time, we never have to get to the very top rung. So the first rung is we're going to clarify the facts. So when we first are alerted or concerned about something, just clarify that we actually have their facts. And the best way to clarify the facts, if you feel safe enough, is to speak to the person to assess what actually has happened and is there risk to the patient. And then if the clarifying the facts with the person is not helpful, you can discuss it at a unit level. You can discuss with other colleagues, a trusted peer. If that doesn't work, you can talk to your supervisor about your concerns. If that doesn't work, you can think about what other safety channels do you have in your hospital. Do you need a check-in from the safety and quality team? Do you need a peer review? Do you need an ethics consult? If you feel that it is rising to the level of a need for formal discussion, then you want to document that as you're escalating to leadership, meaning the supervisor, the unit management, then the supervisor, the medical director, and then all the way up the chain of command. External reporting to a nursing board or a physician board or whatever the board is usually is only necessary if there has been a clear legal violation or violation of ethics. And before that is considered, we would say seek counsel or speak with your risk management team. If you still feel like morally that is something that needs to be explored, it should only be considered after those 7 steps have been followed. So when do you escalate? 1, when you have immediate risks. The patient's safety is very clearly, directly threatened. 2, you have an internal failure. You did try internal reporting, but it didn't resolve. And 3, you have a legal violation where ethics or legal or laws are being ethical principles or laws are clearly being violated. So how do you speak up in real time? So for my case that I mentioned about the infant that I had concerns about in the community hospital, speaking up in real time could mean bringing to the attention of everyone that the concerns that the child may warrant services that are not being provided for in this unit, following up with the supervisor or the medical director about the concerns, and then activating transport if it was felt that based on the child's clinical condition and current standards of care, the child met criteria for transport. And if that is blocked at the leadership level, being able to go up to the next level. So thinking in terms of confirming first rung, second rung, and then higher rung. When do you need to be a whistleblower? I think that's a hard question because sometimes whistleblowers have real consequences, and you have to think about the personal, professional, and institutional costs that are involved when you do become a whistleblower. It should not be your first step. The first step, as we mentioned, should start with your internal reporting and then escalating when that fails, rules for external reporting when that fails, and things to consider if you have decided, I think I do need to be a whistleblower in this case, and what are the ramifications of that process, and sometimes that involves having counsel. I do want to say before proceeding to the whistleblower route, I often find that in mitigating communication conflict that we need to just kind of review the difference between a disagreement and an egregious violation. So is this truly an egregious violation, or is this a difference in standard of care? So not every clinical disagreement is a violation, and not every violation is a disagreement. And so confusing the two is really how people maybe get labeled and how dangerous patterns are allowed to persist. So is it a reasonable disagreement? 2 competent clinicians, both within an accepted standard of care, they choose different approaches. They have different ventilator strategies, different antibiotic choices, different timing for a procedure. There is a genuine evidence base for both. They both are choosing different approaches to this problem. So if it's really a reasonable disagreement, some great venues for that would be a journal club, a case conference, a morbidity and mortality review, but not necessarily escalation, not an ethics committee, and certainly not external reporting. So that's a reasonable disagreement. An egregious violation, if you look on the middle of the slide in the orange block, is a clear breach of standard of care. Patient harm or risk is present. And of course, in that case, you are going to require some type of escalation and sometimes external reporting. So whenever I find myself facing these scenarios, I'm asking myself, what did I actually observe? What do I actually know? What do I actually know? What is the professional standard? Are my facts verified? Or have this become a myth or a legend on the unit? Have I used internal channels? Is the patient's safety at immediate risk? And do I need legal or ethics counsel? Is there a chance that I'm wrong? I think we should always ask ourselves, is there a chance that I could be wrong? And so obviously silence is not an option when there's an immediate threat or harm, but there can be a long range in between navigating those on the process to disclosure and helping to do things that genuinely improve your system. So finally, I'd like to just end with caring for the caregiver. So we've talked a little bit about the difference between adverse events and iatrogenic harm. We've talked about why the ethical principles around the care of children when iatrogenic harm occurs, particularly when there are untoward consequences, why it hits a little differently, and why these losses may echo for many, many years. We've talked about some frameworks for disclosure. We've talked about some frameworks for escalating. And now I want to talk about taking care of ourselves and the very real issues that can happen around moral distress, second victims, if we don't make sure that we have improved systems. So what about the weight we carry? We hear the term moral distress a lot. We're hearing it more often now. This term was first coined in 1984 by Andrew Jaminton, and it's the experience of knowing the ethically right course of action and being unable to take that course because of an institutional or systemic constraint. It's not indecision. It's not a lack of clinical knowledge. It's not moral weakness, and it is not a lack of knowing what you might do under different circumstances. It's specific psychological injury to the clinician or the care team who knows what should happen and watches it not happen, knows what should happen through their lens and watches it not happen. And because of that, it may happen because of staffing. It may happen because of hierarchy. It may happen because of a particular family dynamic. It may not happen because of a policy or because of any of the 100 things that shapes care, which makes care, particularly in pediatrics, in the land of these family dynamics, in the land of consent over assent, so challenging. So I want to just remind us that moral distress can start because of disproportionate care, communication failures, the hierarchy silencing. You are there caring for the patient, but you don't feel seen or heard. And understaffing can compromise both patient safety and the livelihood of our staff caring for the patients. Moral distress isn't just moral distress, it can become burnout. And the beginning of moral distress as burnout is asking yourself if you're good enough to continue to do this job. Physical emotion, psychological exhaustion, compassion, fatigue, where you really start to question your meaning in your work. Are you even making a difference? You don't even recognize those parts of yourself. And moral residue that really can persist for years or decades. The case I shared with you guys at the beginning of this talk is something is a baby that I took care of 20 plus years ago. And so that was before even levels of care were formalized. Well, recognizing, because I go to different hospitals, that care may look different in different systems. And then some of the end results of this can be the guilt, the shame, unnecessary turnover, and people leaving the profession just for self-preservation altogether. So what do we know that can be lifelines for the weight that we carry? We've talked about having a disclosure team. We've talked about having a process to talk to our teams about this. I can tell you that for the majority of my career, I have not experienced a process that allowed psychological safety for debriefing in the context of iatrogenic harm. It looked more like Grey's Anatomy looks when they're going through the M&M. Certainly for the latter part of my career, I have seen that. I think when we know better, we learn more and we do better. And it's been nice to see the evolution, at least in my work environments, of safe spaces to have these conversations. But I know that I carry moral residue from environments that were not as safe as the environment I'm currently in. So what do these support strategies look like? Peer support, somebody who knows the clinical context. Ethics education, having the language for what we're experiencing can be really, really helpful and not diminishing what people are experiencing when they are navigating this process and feel unseen, unheard, or invisible. Having communication training, having a framework to be able to partner, allow for disclosure in an honest way that aligns with the institution's frameworks or the institution's guidelines. And then leadership engagement. I mean, it really does have to start at the top. We learn from the top how to be transparent in disclosure. We also learn from the top if we can't be transparent in disclosure. So if you lie awake questioning that, I would say applaud you because that's where it starts in making sure we do better. So what do we do? How do we prevent clinicians, our care teams, from becoming casualties? We know from the research around the RISE, the initial evaluation of the effectiveness of the RISE programs, that what people have shared with us who experience what we consider to be what we label as second victim, people who are navigating moral distress after caring for a patient that experienced an adverse event or adverse consequences, is that silence just makes the wound grow bigger. People, 42% of those navigating those experiences have psychological distress. 32% question their own self-efficacy in the role. And 81% really crave peer support to navigate that. So people are asking for peer support, brief time away from the unit, any time away from the unit, to step away and recompose. And how often are we not allowed to recompose? How often are we put in situations where we're admitting the next patient? I know we hear that often from our interns and residents that they don't even have time in between some of these experiences to reset and just quiet spaces to recover. And so I look at these peer support really as emotional first aid, just like you would not see someone bleeding and not intervene. If we are navigating these experiences, we have to hold space for people need that to be attended to as well. Our families need to be attended to, our care teams need to be attended to, and our systems need both to be the most safe system for everybody providing care. So how do we build systems that are worthy of trust? And I always like to say worthy of trust. Sometimes I feel like when we meet families, we presume that they trust us, but there are families that come to us who actually don't trust us, and they have reasons not to trust us because of their own lived experiences. So how do we ensure that we are worthy of their trust and that we maintain and take care and be especially attentive to keeping their trust? So to do that, we want to be a culture that learns from failure. And the way we learn from failure, we learn that from Johns Hopkins Safety Science, the initial work in that area is that system improvement is more important, is the better way to go than individual blame. We don't learn by individually blaming our care teams. We want to promote psychological safety, and you want to distinguish what was routinely a human, just a understandable human error from what might be egregious or unacceptable behavior. We want to have transparent disclosure. We talked about the candor approach. We talked about structured frameworks for disclosure, and we talked about RCAs. We want clinicians who care. We want clinicians, care teams who are taking care of these patients to be able to get support. And I would challenge you to look at your debrief process after adverse events. Does it happen immediately? Does it happen a couple of weeks later? Does it happen in a more formal environment like a sports rounds? Or do you have many environments that can happen in the immediate process and then longitudinally over time with trained responders? We want to think about, for at least for me, we have clear risk stratified data for the care of extremely low birth weight infants. And so I think about what are the protocols that we have in place that ensure equity. And you should also think about that for your systems if there are cases that are staying with you. Remembering that our families are partners, they're not problems. And really, do you have family on your safety committee? Do you have families as part of your RCA? Are families really collaborative in shared decision-making? What type of advocacy training does your hospital allow safely for families to continue to partner in making sure this does not happen to another patient? And just remembering that every era is an opportunity for improvement, and every era is an opportunity to learn so that we can even convert all near miss opportunities into no miss. So what are the ways that we're learning from our safety huddles? What are the ways we're learning from our M&Ms? What are the ways we're learning from our RCA? Or are people leaving those processes feeling shamed or blamed? So finally, before we end and open up for a little discussion, if you have some questions, I hope you guys have those in the Q&As. If you have reflections about ways you've navigated disclosure or psychological safety in your hospital or longitudinal support to mitigate moral distress, love to hear about all of those things. I'd like to just close with what I am referring to as the 4 C's of the response. So in terms of when harm occurs and there needs to be disclosure, we want to start with clarity. We're going to start with clarity. So we're not going to make up facts. We're also not going to hide facts. So what do we know? We're going to name what we happen in plain language. You're going to separate what is known from what is not known, and you're going to commit to a clear timeline. That could be another C, committing to a clear timeline for what comes next, so families know that you're going to be there. So what we know now and what we don't know. That can be a very short conversation initially while you're navigating the uncertainty. The next thing is courage. Easier said than done, but really the courage to say the hard things out loud, to disclose when silence would be easier, and escalating those concerns up the ladder rather than letting harm go unspoken. And remember, silence for our care team is the same too. That's a wound that they're carrying. So really to be able to speak out loud, the hard things to speak out loud. I'm so sorry you didn't feel seen can be really, really important. Compassion. Meet the human cost. We said we're going to apologize genuinely, and it doesn't imply liability. And then we're going to collaborate as a system, not as a solo. So we're going to tell the truth early and often. We're going to define our institutional interests, and hopefully our institutional interests align with our interests for our families. And then equity is risk appropriate care. So I hope that you guys are able to take some of these with you into the week. I'm really looking forward to the discussion. Thank you for allowing me to share a little bit about some of the things that make me go, over the course of my career. Thank you. Here are some references for you guys. I think the PDF may be available if you want to do a screenshot. I specifically want to draw your attention, if you're not familiar with the Candor framework, to that framework, as well as the AUP policy on the disclosure of adverse events, and the work around RISE and second victim support. Thank you.
All right, I want to say thank you to Dr. Major-Kincade. This was an amazing talk. Thank you so much for sharing that with us today. I personally, while I'm waiting for things to pop up in the chat, which they're finally starting to come in, I wanted to sort of say, like this is something that's really, really hard, right? When something goes wrong, like you feel so personally responsible for it as the clinician, and like it's hard to go home, you know, and manage when like your job is to fix people and like it didn't work today. And I think in neonatology especially, like it's funny because I must like take a lot of credit for like all of our big successes, because when we don't have a success, I'm very like personally like distraught over it, and it's very, very, very hard. So I was sort of wondering, like I thought a little bit about the case that you talked about, the Hopkins case. And I don't know the details of that case, and I should probably look it up, but like I just sort of think that that's startling, actually. The dehydration part seemed really odd to me, because usually that is a sort of slow thing to develop, and it feels like that's the sort of thing where like somewhere along the way someone could have made a different choice or listened more. You know what I mean? Like this isn't just sort of like a single mistake. This feels like this was an ongoing pattern of like weird choices. Like, can you talk a little bit to like, I guess what I'm asking is like when there's like a train going the wrong direction and it feels like no one can kind of realign it, even though it feels obvious that it's like wrong. Like, you know, like it feels like somebody would have picked up on this or said something, or like it couldn't sort of correct.
Yeah, I don't have the specific details of the case. The mom tells a really moving story on her video of over the 4 days watching this happen, and I wonder if you know, sometimes when you leave an ICU environment, and you go to the discharge environment. I know for me, when I'm receiving a patient that's close to discharge, you just kind of presume they're at their baseline and they're going and they're fine. And I think the subtle things that the mom was recognizing when the team realized, when you go back retrospectively and put it together, the patient did look like sepsis, but like in the moment, I think they seemed like little things that weren't a big deal, and she was on the path to going home. So it's very moving to hear her. She narrates those 4 days of being dismissed while feeling that something was very wrong, but being told repeatedly that everything was okay. So I also am looking at it through the lens of 2026 and not the lens of 1999, 2000. And I can imagine in 1999, 2000, I'm going to date myself. I finished medical school in 94. I'm almost 60. I know I don't look it, but I can imagine medicine being very much still very patriarchal that way, and being very dismissive of families sharing their concerns or things they would like us to look at, and being very, well, you're not the doctor, I am. And so I wasn't in that scenario, but I know that over the course of my career, I have seen spaces change that allow more alignment and collaboration for families as experts in the baseline for their child than perhaps what I saw at the beginning of my career.
Great. We do have some questions in the chat, so I'm going to start reading them to you. Tanya Aurora, oh, hey, Tanya, says, this is such a wonderful talk and a call for our systems to be more trustworthy. And yet, in this moment, I don't see our systems moving towards more transparent disclosure and partnership. What do you think are the barriers at a systems level, and how can we as individuals create a more healing culture?
Tanya, you would excellent. Thank you so much for that. Thank you so much for that question. I agree with you. I think one of the biggest barriers, I hate to say it, or sadly, is the fear of it being in a litigious society, and the fear of the consequences of disclosing too much. And when we do disclose, will the system take ownership for the disclosure, or will the system say, Dr. Kincade messed up, so Dr. Kincade can leave? And so I do think that is something people have to weigh, because most errors are systems errors. They're not individual errors. But we see that time and time again, that one person may be put up as a scapegoat for an error that really involved multiple people. And I think the bottom line is that it has to start from the top up. From the top down. So if you work in a system where when you first bring up a concern, the concern is you being challenged about, is this a valid concern? Is it a valid reflection? Or you've been told that it'll be looked into, but you come back the next month and it still hasn't been looked into. That is kind of where we get eroded as team members. So I do think, unfortunately, I believe one of the biggest barriers is just a fear of liability. And often what's interesting about these cases, about most of the cases in this space, is if we're not transparent early on, it actually leads to more liability if you're not as transparent as you could be about what you do know, not necessarily who caused what, but that an error has occurred that has caused us harm. So that's one thing I would say, Tanya, is that some of our systems are more aligned with medicine has become more of a business, and unfortunately some systems may be more aligned with institutional reputation than they are with patient advocacy or family-centered care. And I think everybody wants the same thing. I think at the end of the day, what's the cost for paying to get the same thing? And for some institutions, because of the resources, because of the way the system is set up, the cost for sometimes taking a different route is too high. And I certainly have seen that in my career, where people were weighing the pros versus cons between taking a different route or taking what some people say is a quote unquote high road, and then losing the system or losing staff or the repercussions of that. And now no families can be served. So I think that the truth is somewhere in the middle, that when we recognize something, just being in a system where somebody can hear me first and talk about once we have the facts, how can we make this better? And what does that look like in our hospital to make this better? And I think if those of us who are on the front lines could hear that routinely from leadership, that would change a lot. But sometimes you don't always hear that. So, but I think liability for me, what I've seen over the course of my career is worries around liability and people being a scapegoat for a system problem.
Awesome. Skylar, who is our new bioethics fellow, has kind of a two-part question that's in here. So she says, first, as we gain the ability to support patients with medical technology longer, which was maybe not as possible before, how do we approach the increasing moral distress surrounding the muddied waters of this technology, such as ECMO? Wait, and then she continues, in addition, how do we explain uncertainty when it makes strides in medical technology or one aspect of medical care, but other areas do not progress as quickly or as well? How do we deal with differing levels of certainty among medical care? I can envision a family saying, how do you know X, but you don't know Y?
Oh my gosh, I think that's another talk. I love your question. You
Yes,
described my
Terri, tell me.
candidates.
I would like to know this.
I was about to say, Stephanie, yes, yeah, that is a wonderful question, and certainly I'm going to use neonatology and the HCICU since you kind of gave those examples. You're right. We are living in a world where we can do all these things. We can diagnose so many things before patients even get here. We have patients that can be delivered, and they can be if you didn't have, if you have you didn't have kidneys before, you had low fluid and you had poor lung development, now you can be born and put on dialysis. Maybe we can grow you and you can have something else. We can do all these surgeries for single ventricle disease or we can resuscitate 22, 23 weekers and we can get you so far, but we might not be able to get you home. And so I do think one way, I think physicians in general always struggle with uncertainty. As Stephanie kind of said at the beginning, is clinicians, I won't just say physicians, all of us, I mean, just in life, in my regular life, in my personal life, I struggle with uncertainty. I want to know everything my kids are doing. So, but what I want to say is one of the things that is really important about your question is many families who navigate a long journey where they got really, really high technology at the beginning and then there were less options later, so they're having to re-go. Remember those very first discussions. And I would challenge those of us who are present for those very first discussions to be honest about we may be able to offer something to keep you alive and get you out of the delivery room, but the goal is to get you home. And we might not be able to get you home. And sometimes families don't always hear that at the beginning because they are hoping to survive the initial process and be able to see what's available and see how it goes. And then after it evolves, we have more information and then we can kind of give them more definitive information. So I think families actually can hold uncertainty, but when we have additional information that lets us know that the process is futile, that we have less options, it's our job as the teams to come back and say, we were here, but we're in a different place now than we were before. I actually had a family a couple of weeks ago that said, well, you just said a couple of weeks ago that we were doing great and you know that my chances on ECMO are XYZ, and they gave a number like 90%. And now we have all this other different information with multi-organ failure, several failed attempts to come off. We have different information now than we had before. And I don't know that we always are able to name that very concretely for families. Different place now than we were before. When your child was born, we had this and we were hoping for this, but we're here now. And these are our options now. And we've had to have some really, really, speaking to your points about technology, we've had some really hard conversations last week where we had to literally say to families, the extent of this amazing technology was to be able to get you out of the delivery room. And the most compassionate thing that we can offer now is a way for you to be able to say goodbye. And that's hard. So families can hold uncertainty. I think sometimes we expect families we expect families to be more definitive when we actually haven't been definitive. We're still saying, we can try this, maybe this, maybe this. So just being really clear about what we know and what we don't know, and when we no longer think we can achieve those outcomes, I think can be helpful. I think the technology is going to continue to increase. And actually families are now using ChatGPT to interpret our technology and tell us next steps. I had a mom last week said that she puts all our notes in ChatGPT and ChatGPT tells her what to ask about the next steps. So it's not just the things we're doing, it's the things that we could potentially be doing. And I think we have to be able to respond. It's the difference between doing things to your child or doing things for your child. And when I feel like I'm doing things to your child, but not for your child, it's time for us to have a different conversation and being firm in that. But I think families often handle uncertainty better than they handle the finite conversations. But when we do have finite information, I think we have to be transparent about that.
I'll say from some of my own work, talking to families about tough decisions, we found that when there is uncertainty, there is room for hope. And when there is more certainty, like that is good, but like sometimes hope goes away. And so there's kind of an interesting balance on sort of what they appreciate. Okay, so here's a good one from an anonymous user. This is one that I can relate to. This was such a thoughtful and informative presentation. How can families effectively advocate for their children and escalate concerns without being perceived as difficult? And I am already like the difficult mom at daycare when there are like health related concerns, you know what I mean? Like they'll be sort of like, well, I'm no doctor. And I'm like, you know who is though? Like of the two of us. And so like I'm always trying to like, walk it back and like not be rude, but like, if you want your concerns heard, like it's really hard to react in a way that is constructive when you feel you're definitely being dismissed.
Oh my gosh, I love your question. And Stephanie, I had the same thing. I wish my kids had pseudo names in daycare because they would be like, oh, we got a Kincaid in here this year. And so, poor children. So, but what I want to say is, I love your question because one of the things we can do is normalize a family's ability to advocate for their child and inquire questions. So I think in medicine in general, sometimes when someone's asking questions or wanting a different opinion or asking for more explanation, we sometimes can take it personally as, well, you don't think that I know what I'm doing, or you think I'm not giving you good information, but like normalize their ability to advocate for their child as a loving gesture. And so one of the things that we kind of model when we're, especially if we're called saying if the mother is labeled as difficult or the father's labeled as difficult, and then we ask them to tell us, can you tell us some of the things that you've observed that make it difficult to talk with this family? And then, teams will say, well, they keep asking the same questions, or they keep asking about a miracle, or they're in denial, or something like that. And we can say, gosh, I imagine that I can't imagine how scared they are. I can't imagine how scared they are in this situation. And I will say to families, thank you so much for your questions. You're such a fierce advocate for your child. I can see how much you love your child. And when I hear these questions, what I hear you asking me is, am I doing all I can do as a parent, which is what we would want to be doing if we were in that situation too. So I think families, it's not the family's problem if we are labeling them as difficult. It's actually our problem that we have attached that label to them. The family can advocate how they advocate, and we can be intercessors for the team to kind of navigate that. Now, sometimes families have kind of figured out ways to make our jobs more challenging as part of their coping with the illness. But I always am more worried about the team. When the team says this family is difficult, what I hear is moral distress in the interactions of trying to care for this family. And how can I support this team member who really wants to be able to communicate with this family better? And what are the tools that we can kind of help to model? So I would first ask about the adjective we're using, what makes them difficult. Too many questions. Do we need to find other ways to explain the prognosis or the treatment plan, or do we need to name their fears? Do they need support from IDT team, social work chaplain, or somebody else who maybe can better elucidate what's behind their questions? But I really want to be able to say to the team member, I can't imagine how hard it is to navigate that. You guys are doing so much. In my time with this family, I found that this family responds well to XYZ. So the labels difficult, angry, denial. One of the things I had a mentor share with me, I know we're running out of time, is that this isn't a difficult family. This is a family navigating difficulty. And just hearing it framed that way, it's a family navigating difficulty. And my gosh, how would I navigate it if I was in their position? So, but the labels, for me, one of my pet peeves is stigmatizing language to characterize families, like difficult, angry, mad, passive aggressive. Even if Tanya's here, even if we're saying they're lovely, what makes this family lovely and what makes this family difficult? Are they lovely because I don't have distress in caring for their child and we have aligned communication? Are you difficult because we don't have aligned communication? And where can we meet in the middle about that?
All right. I do believe we are out of time. There were a couple other interesting questions in the chat talking about sort of how to deal with this if you're not the person who's in charge or the leader, or how leaders can really improve this. Sahar, hello, posted things about transparency where promises are made that are aspirational more so than realistic. So hopefully folks can connect. Dr. Terri Major-Kincade, I think she had, if you guys look in the Q&A, there is a link to a handout. Oh, but it needs me to log in, so I'm not sure how easily accessible that actually is. But we here at the Bioethics Center know how to get in touch with Terri Major-Kincade. So should you want more information, should reach out to her with more specific questions or want a copy of her handout, you can let us know, and we're happy to connect you and see if there's another way that we can share that widely. But thank you so much. This was such a great talk. I feel like I always learn so much from these. We'll come back in a couple of months with our next one. I don't recall off the top of my head. Jeremy, you're on, and Angie, do you guys know what the next one is off the top of your brain?
I know our speakers are Dawn Hood Patterson and Haley Scoggins, and they're going to be discussing issues, I think, of equity in the current times, something to that effect.
I believe it's November 3rd.
Yes.
Oh, look at
It's
that.
the Tuesday of election day. So
Yes.
here.
Oh yeah. Okay, cool. Well, we'll see you all
channel
back
your
then.
anxiety into. That would be a great opportunity.
Exactly.
Thanks, you guys.
We will see
And
you
real
all then.
quickly,
Thank you again.
Oops, I was going to say real quickly on the handout, it's when they go in to do their evaluation, this link should be in that. That's what it's leading you to. So if you did sign into Cloud CME, when you do that, you'll see the link to the handout there.
Cool. All right. Thanks, everyone.
Thanks, Terri.